Hi everyone, welcome to day 3 of Water and Health. Thanks for those of you hardcore folks who are sticking with the healthcare facilities track.
Yeah.
We've got another great session today, this morning, and then also this afternoon. And make sure you come back to Central Hour for the What's Next in Water and Healthcare Facilities event. But today, introducing myself for those of you I haven't met, my name is Ryan Cronk. I'm with the Water Institute. And today we're going to be talking about what works in WaSH and healthcare facilities around sustainable management models. So with growing momentum around WaSH and healthcare facilities, the sectors move beyond simply assessing conditions towards developing effective management solutions to address this global challenge and ensure that the interventions that have been done in healthcare facilities are sustainable in the long term. And we also know that no two contexts are the same. WaSH in healthcare facilities is obviously very diverse with things like waste management, water supplies, toilets. Facilities have different sizes. There's no one-size-fits-all approach for sustainable management. And so today what we're going to do is we're going to start off with a report or a summary presentation of a report that we did with the World Bank, UNC, on sort of a landscape analysis. And then then Dr. Darcy Anderson will be presenting that. And then we'll jump into with 4 real-world case study examples from really diverse contexts to kind of unpack what this can look like in different settings. And then we will have our presenters join us for a panel, joined with Dr. Mary Ashinyo, who is joining us from Ghana, to be our government representative. All the other case studies are other service provider types. And then Claire Chase will be moderating that panel. So that's sort of our run of show for today. So Darcy, you want to come up and kick this off? I just need to click the next.
The clicker is not working, and I'm not seeing the slides on.
It's a projector. Just click this, and then that should work. Yeah.
Great. Okay. Okay. So I'm not telling you anything that is new to you all. I'm sure you're all well aware. You're all in this room because you think management is important. We built a toilet, a waste management facility, an incinerator, a water supply. We don't appropriately maintain it, it breaks down, and then people revert back to whatever the conditions before the infrastructure improvement was done. And then we've wasted a bunch of money building infrastructure that is no longer functional. So what we're looking for is building infrastructure and then having this black box of appropriate management, and we'll talk about what goes into this box. And then hopefully we come out the other side with our infrastructure investment being nice and well maintained, and we've saved our money, and we have a nice cost-effective investment because we've taken care of it appropriately. So today we're going to try to figure out what goes into this box. So I'll just resume my sort of job today is to give you a little bit of background information so we're all on the same page with some terminology. When we think about management models, we can think about a couple of different key functions that those models provide. One is regulatory, ensuring compliance with relevant local and national policies and guidelines. This is things like water quality guidelines or waste management, like technical guidelines. But then we also see things like regulations related to tariffs, service levels, consumer protection, etc. So it's both technical, economic, etc. Then sometimes, but not always, we may have a role for external support and oversight. This is guidance, technical assistance, other assistance to strengthen and support the service provider. Then there's management, which is sort of your day-to-day strategic decision-making and planning about operation and maintenance of the service. Day-to-day, as well as ensuring long-term sustainability. And then we have the service provider, These are the people that are actually on site delivering services to fulfill the mandate of whatever basic advanced service level is required. Okay. This graphic is a little complicated. I'm not going to go through all of it, but this is just to show you that we can think about different types of management models based on who fulfills these functions. So the one that's perhaps most familiar to folks is basic community management, where we have relatively little going on in terms of regulatory functions or external support, and primarily the day-to-day management and the service provider function is fulfilled by the community without engagement, for the most part, by other stakeholders. And then as you add more stakeholders in, you start to see different management models here. We can have community management plus, where the community is still providing these management functions and service provider functions, but we have other stakeholders who are involved to support the regulatory functions as well as the external support and oversight. Local government models, public utilities, private models all exist, with different stakeholders engaged in these functions. So the question that we're here to answer today, not all management models of the same type are equally successful. So we can have community managed systems that work well and community managed systems that work less well. And so there's more going on than just the management model type that influences success. So we can think about a couple of different things. We can think about organizational characteristics of the management model. This is things like the structure and capacity, things like the team experience level, leadership, human resources capabilities, the resources that are available to the team, so funding, materials and equipment, processes for budget allocation, cost recovery. We can think about access to knowledge and information amongst the team, so things like training, opportunities for learning and feedback, potentially communities of practice. We can also think about accountability and incentive structures. So this is things like the service agreements and specifications, job descriptions in terms of reference for staff, standard operating procedures, regular audits and public reporting. There's other factors as well, or other organizational characteristics that influence the success of management models. I cut out a bunch of slides to this, but we can think about all of these factors that are aspects of the organization that influence the management model. We can also think about the influence of context. So when we think about context, these aren't characteristics of the stakeholders involved in the management model, but the context in which they're working. This is things like policies and laws, legal mandates for service provision, for example, structure of the health system, WaSH standards and guidelines that may exist. We can think about external pressure and incentives. So internal pressure and incentives would be things like formal service agreements between the service provider and the service authority. But external pressure can be things like public pressure, public demand for quality services, market demand and competition, advocacy campaigns. We can think about communities, population behavioral norms, social cohesion and engagement, particularly with community management models, willingness to participate in that model. Of course, geographic conditions, things like the hydrogeologic, climate-related hazards, road infrastructure to transport goods, all of these will influence your management model, as well as the epidemiologic conditions, so the local burden of WaSH-related disease, population growth, etc. Again, there's more contextual characteristics than I was able to fit on this slide as well, but these are the types of things that we're thinking about that influence management models. Okay, so you may be wondering, which management model do I choose? There's many different ones available. Which one is going to work for me? Unfortunately, I cannot answer that question for you and say, oh, this management model is going to be right for everyone. Understandably, there's a bunch of nuance to this. It depends on what your context is, who your stakeholders are, in terms of what's going to work best for you. As Ryan mentioned, the UNC did a rapid literature review and stakeholder consultation. Sounds like there's a policy brief. Yeah, there's a policy brief written up for this work. So this is where these findings come from. I'm happy to field questions during the panel later. Some preliminary findings from that. We think that private management models are more likely to work in certain contexts than others. So for example, where there's sufficient density of healthcare facilities or other clients to support profitability, there's political will for government funding of that private service provider or sufficient revenues from the community for that service provider to recoup costs. When we think about local government models, key driving factors are there's autonomy for the local government to act, as well as political will for decision-making and action, and then adequate resources and technical capacity among your local government stakeholders to perform those management functions successfully. And then community management models, we see these often in situations where there's either low willingness or ability to pay for professional services. But for that to function well, there needs to be willingness for communities to engage in the day-to-day management. So high social cohesion and engagement often drive success of these community models. So while I can't tell you this model is going to work best for you, there are some factors that we see emerging that we think may be more universal in terms of driving success of management. Clear standard operating procedures where they exist, they've been written down, and critically, someone has been assigned responsibility to perform them. We think that this is a success factor that likely operates across different types of management models. Funding, obviously, is critical, but specifically funds that are earmarked for operations and maintenance. So not just there is some WaSH funding available, but there is specifically a dedicated line item for operations and maintenance of that infrastructure. Policies and incentives balance the need for new services against the need to operate existing services. Often we see mandates structured in terms of reaching universal coverage or adding a certain number of new services, which is important. But sometimes those mandates for new services compete with the limited resources to operate and maintain existing infrastructure. We see, interestingly, non-WaSH skills as being really important for management models. So things like accounting skills, logistics, procurement, ability for human resources to attract talent and navigate local government bureaucratic systems. All of these they're a critical part of the management model. And finally, engagement from local government. Even if local government is not necessarily the service provider, having local government buy into the importance of WaSH operations and maintenance, where they're supportive of the mission, and you have their buy-in, is also critical for management model success, even if it's not a local government management model, so to speak. Cool, that's it for me.
Any quick questions for Darcy?
Yep.
Are we miking?
Sorry, I thought we were taking panel questions at the end.
Take you questions now.
Question on this. Did you feel like when you did this, it was specific to healthcare facilities, or did you feel like this could be, like, I'm sitting next to a colleague who does WaSH in schools, like, is this applicable beyond the healthcare setting?
Yeah, so this project actually we did healthcare facilities and schools together. There's a little bit of, we saw some differences between them. So for example, schools tend to have more community management than healthcare facilities. We hypothesize because the services to some extent are less technical and there's less of them. So you're not doing IPC, you're not doing waste management in the same way. But surprisingly, a lot of things are universal. I mean, maybe unsurprisingly, like standard operating procedures and having someone assigned to them works well if you're in a school versus a healthcare facility. But it seems like the policy brief will be available and shareable, so that you'll find additional information in schools on there as well.
Other questions?
Yes, this is Steve Sarah from Save the Children. First, Darcy, I just wanted to say kudos for the way you interpreted and summarized all this information. As you know, under USAID's Momentum Project, we were trying to do something similar, which we never completely finished before the program closed. But I think you did an excellent job of trying to like tease out all the factors that might exist. One question I had was on the characteristics that you might consider. I didn't see anything related to like the size or the patient load or the type of services that health facilities provide. I was wondering if that might be another characteristic worth considering. In some of the focus group discussions we did and the KIIs, we found that, like, especially with waste management, facilities often said like they didn't accumulate enough waste to outsource their services, so they preferred to handle it internally, even though they weren't doing a good job of it. So yeah, that's just a question. And then, is there like some element of quality of service in these characteristics as well? I didn't see them, but maybe I missed it.
Yeah, so yes, those things are important. When I copy and pasted the full sort of appendix of characteristics that we looked for from our report methodology into these slides, it took up about, I don't know, 15 slides.
Okay, so it's just not comprehensive
Yeah.
on the slide. Okay.
I didn't think that this audience probably wanted to sit there and go through all the nuance of it.
You were
But
wrong.
Steve, you and I will go through the
This is the
nuance of it.
hardcore group. We want to see the table.
Yeah, I'm happy to chat after the session in a bit more detail and sort of send you the full list if you want.
I'm curious about Nkavanjero from HUP. I'm curious about any of these from the faith-based health facilities and private health facilities, like private for-profit. Did you see any differences?
That's a great question. I'm trying to think. This was sort of a fairly rapid literature review and stakeholder consultation. I don't recall, Ryan, feel free to jump in here. I don't recall seeing a lot of information on faith-based management models. So that's definitely a gap in the evidence that would be, given the prevalence of faith-based organizations in WaSH and healthcare facilities, that's definitely a gap that needs further exploration. I don't know how much insight I can provide to you. I imagine that some things would be sort of more universal in terms of success drivers, but others would be more specific to faith-based organizations, and we'd need to do more exploration to know which ones specifically. Sorry.
I hope we have a case study later that can maybe elucidate some of that information. So, any other quick questions for Darcy?
Great. Thanks, everyone.
All right. And so our first case study up is Dr. Nuhu Amin from ICDDRB and PhD aren't you almost done at UTS? Close enough.
Close enough, yeah.
There you go.
Still struggling. Yeah. Okay, thank you very much. I think Darcy has made my life a little bit easier because she already provided some background here about the management strategy. So I will also give you same things that how we have actually developed an innovative wastewater treatment plant. This is the first in Bangladesh, 24 KLD, 7-stage wastewater treatment plant to treat one of the largest 250-bed hospitals with the effluent quantity is 24 KLD. So it runs 24/7, and I'm going to share this story with you that that how it actually worked. Actually, the innovation is not only the treatment system. This is very common around the globe, but the innovation is like process innovation, I would say, like bringing people together to actually continuously manage this system so that it's sustained. So we have installed this in 2022, and still it's running with that system. So what is the current management and operation system of healthcare settings? I found I worked since 2019 at WaSH healthcare facility, particularly in large hospitals in Dhaka. And I found that the hospital directors actually, hospital and like public works division, these two divisions work together, but it's not like transdisciplinary approach, it's like multidisciplinary approach. They don't own whole healthcare facility, they own their own work. Like hospital directors only think that their mandate is to treat the patients, not the infrastructural management, large infrastructural things. Public Works Division, they only think about fixing, not linking with the disease, not linking with the well-being of the disease. Similarly, you can see in this model that Ministry of Finance and LGRD ministry were actually very big actors for like supply chain and funding and other things, mega structures, but they are not directly actually linked with healthcare, like Ministry of Health, then they work with Public Works Division and other partner. At the same time, community is not involved, academia and industry. They are also not directly involved with the healthcare facility improvement. So that's one of the biggest challenge I found. So this is, for my current research, I found this is the current model actually going. So what is our future or like our ultimate goal for this? Sorry, this should become with the like slide, like one by one, but it's actually coming together. So usually you can see that within the yellow circle here, we try to bring these people together from the beginning of the planning. So this was funded by the Ministry of Finance through the Ministry of Health. And we have actually bring academia particularly, academia, Ministry of Health, Public Works Division, more with the Ministry of Finance, so that, and also the Department of Public Health Engineering. We also bring, here is Ministry of Environment and Climate Change, so that they have the regulation of wastewater management, and also like industry. They are really a big factor for developing wastewater treatment system, water treatment system for healthcare facility or institutes. So how we have actually bring them together here, that everyone have their transdisciplinary ownership for this successful implementation of this project. Particularly industry, we actually contract them. They manufactured in local level, and the local engineers have that capacity to actually build this type of. They have installed this in different industry, but the lacking is they don't know what is going on with within healthcare facility. What are the effluent quality? How much volume is coming? So they don't have that things. So ICDRB and UTS and Bangladesh University of Technology, we sit together and we provided them this information, that what should be the volume, what should be the design, what quality that Ministry of Environment need, and what is the WHO standard. So we actually sit together and build the design. We conduct the co-creation of this system. So academia, role of academia is really crucial while you actually design this type of things for a sustainable solution. The academia or like research institute also have the stakeholders engagement, like efficacy trial, sustainability of the project, and also like very important thing is how can we actually build this with the team, and people can actually own this system. Ministry of Health, how they actually supported us, it's like hospital and directors, they actually provided us land and 24/7 electricity supply they have provided us, and staff. So this is one of the biggest challenge we have, because hospital still don't have that staff who can actually operate the system. They have pump operator, but they don't have operator for wastewater treatment plant. So we are pushing, still not actually having. Shelter, one of the biggest factors, that people need to stay there for overnight, but there is no shelter for external operators. So although this company, private sector is managing this, but they are complaining there is no stay home for them. At the same time, like Ministry of Finance, we are pushing, we have shared this, we have collaborated together and sent this data that this is going to be very effective. It requires very small footprint. I don't require any large wastewater system like we think. So it can be like vertical, whatever the land space, we can actually build this within that land space. And they are also sensitized, and hopefully there will be more funding for this type of things, and we are working towards that. We are also working, put this with WaSH in healthcare strategy, 2025-2030, to adopt this type of system so that our environment is clean. At the same time, this Public Works Division, they have responsibility within the modification of the drain, bringing the liquid to the system. There is a leaking of sanitation system. So we bring them so that they actually fix those major and minor system to the things. So this is how we actually working together to actually make a team, and this is how we still is working. Which context this type of innovation or this type of system can be is, I think the peri-urban or urban hospitals, first particularly more than 200, better to focus on a little bit larger hospital where there is a possibility of funding more patient load, because the system need more wastewater so that they can get some feed. Non-sewage or mixed sewage sanitation, where Dhaka there is no connection with the sewage network, so that's another important thing. Where the land space is really scarce, so we can build this system over there. Also, this is very important that the management system of the hospital, they need to agree and they need to be a part of this from the beginning of the planning. So this is the outcome, the results. So we have tested plenty of biological, chemical things, particularly AMR, diarrhea-causing pathogens, and we have found very successful results throughout last 6 months, more than 6 months. We are testing this every week with BOD, COD, and also we have more results. So I didn't show them here all the results, and you can see this quality of the effluent and the treated water from the system, and the advantage is really it achieved the national standard. As the same time is we can use it for gardening and also car washing, floor cleaning. So this is meeting those standards. Low cost operators, only 2 operators can operate this system, and locally available services there. So I think this can be scaled up and is feasible to things. And this is how it looks like from the outside. You can see this is a very small space within the hospital, and it's the household building. And there are challenges as well, as I mentioned, that sustaining the budget is very difficult if we don't get next funding. Bangladesh is having some trouble with political unrest, and there is interim government. So we are still waiting for releasing the OP for the next phase task. Housing for the operator, lengthy procurement process. So it took a long time for the procurement process. Government required a lot of time to actually signature and other things. Climate and extended flood, political unrest, those are other additional things. Membrane is not produced locally in Bangladesh, so we have to bring them from outside. So that's another challenge that it takes a little bit time. So, but if it is a system we develop, then there will be a market in Bangladesh that they can. So industry usually use this, but there is no cross-checking. There is no efficacy trial of any industrial effluent. So that's a business, and there is a very misuse of this type of technologies as well. And these are some outputs from our initial things. And here is the team who worked very hard, and Julia is one of the chief investigator for this project, and we have disseminated this through the DGHS and other things. I acknowledge my co-donors and also donors. Thank you very much.
Thanks, Dehu. Maybe one quick question, and we'll have all of our presenters will be back up for a panel, so if you have questions that come up, we can ask them then. Any quick ones now, though?
Yes, please.
So I think
For the online folks.
you said this was the largest urban hospital in Dhaka, around 300, 250 beds?
Dhaka has, start with 250 to 500 plus.
Okay.
So this is start with the largest, like tertiary care, large hospital. It's a government hospital, general hospital.
So my question is, yeah, just getting to the, like we were talking about the diversity of context, what size of hospital or primary care facility do you think this is applicable for? Like, what's the potential scale of this approach?
Yeah, so currently we are also mapping 3 more hospitals, and from those 3 hospitals, like we found that in one hospital we need 3 this type of system, because effluent is going different ways. It's not possible to bring everything to one place. So we assess that in one of the DB hospital, the effluent is going very diverse when it's a big hospital. So we plan for 2 wastewater treatment plants. There is one hospital in like Dhaka Medical College Hospital, like it's a very big hospital. So you cannot install one large hospital, operation maintenance will be very difficult. So you have to plan how can we actually maximize, because a small unit easy to manage and it's a low cost, and effluent is easy to manage. But if it is a very large industrial and very big things, number 1 is no space, and number 2 is like cost will be really high to actually manage those things. So, but if you provide a small unit, that's easy to manage by, this is what I understand. And one of the biggest challenges, you cannot bring all the wastewater in one place if the drainage network is very diverse of the hospital.
Great, thank you so much.
Thank you.
All right, next up, we've got Dr. Andrew Armstrong from Time.
Thank you, Ryan. Thanks to the organizers for including us. My name is Andrew Armstrong. I work with Uptime Global. I'm going to be talking today about a model that we've been working on with colleagues at the University of Oxford, as well as governments of Bangladesh and Zambia, on a model that covers rural healthcare facilities and schools. So these are different from what Nuhu was just talking about. These are sort of level 1 community-based healthcare facilities. In this model, this diagram kind of outlines it. Professional service providers that could be local NGOs, or they could be private companies or social enterprises, are contracted by the government to do several things. One is rehabilitation of water points. Oh, also, I forgot to mention, this is for drinking water services. So to narrow down, we're not talking about sanitation, we're not talking about big hospitals, we're talking about rural healthcare facilities and drinking water facilities. So professional service provider is contracted to rehabilitate water points up to a functional standard, and then do preventative maintenance on those water points. They could be tube wells, boreholes, they could, and with hand pumps. They could be piped water systems. They could be, in Bangladesh, we have reverse osmosis systems and rainwater harvesting systems. But they're contracted to maintain them up to a certain standard, as well as doing water safety management, which includes sanitary inspections and water quality sampling and submitting samples to labs. That's sort of the standard management model, but then the results-based aspect of this is that those service providers report to an independent verifier, which in our case is Uptime Global, where I sit. We validate and verify the performance of the service provider, and sometimes we have to resolve any data discrepancies and make sure that what they're reporting is accurate. Then we tell the funder how much to pay the service provider, and the service provider issues the payment, or the payments are issued, and then if there's sanctions necessary, sanctions. We are currently implementing this in 2 national programs. I mentioned in Bangladesh is the longest running. This is sort of a follow-on from the University of Oxford-led REACH program. In this model, contract currently covers 74 community clinics, as well as over 1,000 public schools. So that'll be coming back to the success factor of this, is that we are aggregating not just schools, or not just healthcare facilities, but also schools. And the key point here is that the government of Bangladesh is co-funding this, actually. In this, we are incubating this model with the government of Bangladesh, but committed to 2030, the government provides half the funding, half of the payments that go to the service provider. The rest of the funding comes from our UK-based charity, which we pool funds from different funders in. We are also now in the second year of doing this in Zambia. We have a service provider in Zambia who is currently maintaining schools and healthcare facilities across one district in Zambia. So in Bangladesh, it's Kulna district. We also, I forgot to mention, we have approval and funding to scale to another district. So in the coming year, we will be scaling this up, basically doubling the size of this work in Bangladesh. And in Zambia, we're currently operating in Mumbwa district with plans to scale and funding to scale to the provincial district, which will bring us about to the same scale as in Bangladesh. One of the things I forgot to mention in the previous slide is that the service provider does not receive payment if the facilities were broken down for more than 3 days in a quarter. So any payment that's received is guaranteeing that uptime was delivered. And so that's a clear kind of core benefit of the model, is that we're ensuring ongoing functionality of the service. But I wanted to highlight some of the water safety benefits around this. Because of the enhanced accountability for doing sanitary inspections and doing water quality testing, we have data to show that over time, this model actually leads to sanitary risks being addressed. So in this chart, it's showing over quarters. So this is first, second, third, fourth quarter of the contract, how the risks are consistently being addressed and improving. So the blue is increasing. That means there's lower health risks, lower sanitary risks at these sites. We have a shorter time span in Zambia, but that's a similar kind of trend. Similarly, because we incentivize with our payment model, if E. coli is detected in the water and the service provider takes an action and then follows up with another E. coli test and there's no E. coli in the water, then they get the payment. Also, if there's no E. coli detected in the water and they've done all the sanitary risk work around it, they also get a payment. So what we're also tracking is just responsiveness to indication of contamination in the water. And we're seeing that in Bangladesh, where this model has been running, all instances of contamination, there's an action being taken to address it. And in Zambia, we're still working to get there. Okay. There's a lot. I'm really glad that we had this sort of like scoping study, because there's of course so much that's behind this, but I highlight a few points here. One of the biggest things for us when we try to think about this results-based model that can work at a national scale is there has to be government commitment from the very beginning. It's easy to say, and it's difficult to kind of act out, especially I was very careful about the word that I chose here, intended from the outset, because if we have to say, government, you got to put all the money into this from the very outset without it being proven, that's not going to work. So there's a staging that needs to happen to ensure that government, we don't get too far ahead of public funding commitments to do this model at scale, but that is a critical factor. And we're leaning on the example of Bangladesh to kind of learn how to garner these kinds of public funding commitments to this kind of model. But these are public institutions, or public facilities, and in a lot of cases, not in all cases, but in a lot of cases, government recognizes that their options are, well, we either rehabilitate non-functional water points, or we invest in a model like this that guarantees results. And so institutional coordination is key. Working with everyone from the national down to the local level where these contracts are in place to ensure that there's planning, information sharing, that we're right now, Uptime Global is doing verification, and I can talk more about what that looks like. But the long-term goal is that we wouldn't be doing this. There would be a partner within the country that that verifies service, or the regulator does that work. And I mentioned here as kind of a sidebar, but adequate infrastructure. This model only works if the infrastructure is functional at the beginning. And so there's always needs to be sort of a rehab budget to get basic level of infrastructure functioning. And then the support programs that go around it. So the service providers that we're working with often have experience in doing technical maintenance work, but really on the water safety side, there's a lot of training that needs to be put in place. So training how to do sanitary inspections, how to interpret sanitary risks, how to respond to water quality contamination cases. And then as well, we're working with, so laboratory capacity assessment and development. We're also working with national labs, and which often the protocols aren't in place to really ensure quality of water quality testing. And so we do a lot of work through University of Oxford to build capacity of labs in the areas where this model is functional. So how do we do this? How do we move from pilot to scale? These things are I could probably have these points on any kind of WaSH model, but this is how we're thinking about it. A key thing for us is not just focusing on healthcare facilities, because there's just so few of them. An area-based model where you can have a density of sites that can receive results-based payments. So in our case, if you synergize with schools, you can get a level of funding commitment for service providers that makes it attractive for them, or remuneration that makes it attractive for them. I mentioned to not go too quickly, so well, that's the last point here, is phasing our rollout contingent on government co-funding commitments. So we could get funding from an international funder, but we don't want to scale up quicker than the government is ready or able to commit public budget line item to this. And then making sure you just progressively go from the district to the province to the national scale. So this is the map of Zambia. Where we are right now in phase 1 is Mumbwa district. Next year we're scaling up to the central province, and then all the time with the vision with the government to have this operating at a national scale. My last slide. Happy to answer questions.
One quick question. Yeah, Steve.
Thanks, Andrew. Are these service providers also servicing community water points, or it's just institutional?
Yeah, so in our other contracts, so these are our sort of national models that we're working on. Other contracts that we do, there is community service contracts in place. For many reasons, which you probably understand, the policy environment of community-based water provision is very difficult. There's a lot of countries, there's a legacy of community-based management, and how does the service provider interact with communities? Revenue collection, user payments is challenging. So we have chosen to focus this model on schools and healthcare facilities and public schools and healthcare facilities because of the sort of understanding from government that it's their mandate to provide all the resources to make these systems functional. So it can work in community, there can be synergies with communities, but it also opens doors to a lot more challenges from the policy environment, I would say, if that's clear enough.
Yeah, thanks.
Thanks. Okay, one very quick question. And then anyone else who's got questions, save them. We'll do it during the panel. Yeah.
I have two. You can choose which one you answer. So you mentioned government co-funding is crucial. I'm just wondering, what's the proportion, like how much of the government co-funding would you need for this to be successful? And do you foresee that going forward, this could just be government funded versus a combined model? Second question, you can choose. Climate change, all kinds of risks. How is that built in at all in this model? Are service providers trained, or because you need functional infrastructure, but if there's a flood or water scarcity, like that affects, right? So how does that come into play?
Sure, I'll try to answer both quickly. The second, so this is climate resilient infrastructure. So when you bring infrastructure up to a level of adequate functionality, that also includes understanding climate risks and making sure that these are service providers that are maintaining water points and in the midst of climate uncertainty. The former question, the first question, When we enter into an agreement with a government, so we have MOUs in place with national line ministries, the intention is that this would be a fully public funded model. But we also recognize it's risky for the government to commit funds to that from the beginning. So what we've done with our UK-based charity, the Uptime Catalyst Facility, is we can say we can commit some co-funding to this to demonstrate it at certain scales, but at some point it needs to be taken over. And that's where it's like a dance. And so with Bangladesh, the government is fully on board with saying at scale, this is a government-funded program. They're very proud of that, want that to happen. At this stage, it's 50-50. So half the funding is coming from the government and half the funding is coming from Uptime and our funder partners. And yeah, and in Zambia, it's a similar thing. So at scale, they're thinking about what we're also looking at education too. So like education sector has funding, health sector has funding. How can we where can we find a budget line item to fund this? And it's less than $1 per person less than $1 per student. Per hospital bed or per patient is a little bit funny when you get the numbers out, but it's typically less than $1 per person for the service per year. $1 per person per year.
Thanks, Andrew. Next up, we have Catherine Giroux from HF.
So I was probably preempting when I asked about the because we are also learning, and this is an invitation for all of us to try and work out on what would work best in faith-based and private health facilities, private for profit. So when I got this invitation, I thought about what would be the best information to share therefore. And as a start, one of the things I can talk about is how does the management of faith-based health facilities look like from where we are? And so there are 2 or 3 kinds of ways in which faith-based health facilities are owned and managed. So one of them is dioceses own facilities. And that could be Catholic, I'm talking about Christian faith-based health facilities. So that could be Catholic or any other denomination. And so the bishop calls the shots in that case and might have other people doing the management on his behalf. And then we have congregational facilities that are run by congregations of nuns and others. And I don't have to say much about what facilities are run better because I want to keep my job. And then we also have facilities that are owned by churches, either with headquarters in a country. So the Methodist Church owns that facility and runs it from the headquarters of the church, the national headquarters, or the local church community. So those are some of the models. And therefore, that will determine who calls the shots in terms of what happens. And then the other thing that I think is important to say at this point is that in a lot of countries, I'm sure Ghana will tell me that they are an exemption. In a lot of countries, the faith-based health system is not funded public. They do not receive public funding for human resources, for health, for their supply chain or for infrastructure. They will get once in a while in-kind support or some support from the government, but it's not assured. We have a few countries like Lesotho, Ghana, Zambia, where they're getting a bit of support from Tanzania from the government. And therefore, this means that people have to prioritize in the facilities on what they have to prioritize in the facilities. And therefore, when thinking about what would work for this facility, especially in WaSH, my experience has been, we were trying to do something on the Momentum project that we did not finally accomplish. But this, like I said, is an invitation for all of us to try and see where we go from here. I'm not going to say too much about HAP, but we are an organization that brings together the Christian faith-based health systems from various countries. We are working in 32 countries in sub-Saharan Africa, bringing together up to about 10,000 health facilities. And Christians in Africa are about 70% of the population. And therefore, I said this yesterday for those that were here, I think this would be an important part of community that we need to engage and maybe solve 50% of the problem. I'm going to talk specifically about engaging faith leaders, therefore, as I was thinking, is it a community-based model, facility-based, or is it a system-wide model? And I think it's a bit of all, but I'll talk specifically about engaging faith leaders, therefore, coming from what I said about how they run these facilities. So the faith leaders in a lot of Africa are trusted, and they have influence in communities. So they're able to bring together people in communities. They also own these facilities, so they will make decisions about the facilities. And therefore, we need to, and they will engage, we have faith leaders that will engage the president, they will engage at the national level, and then they will also engage at the community. They own the facilities, I said that. They're able to mobilize and convene, and they also help to, as a bridge. And they're also making decisions at the facility level. So faith communities therefore become a linkage for WaSH because one, we can use the facilities as demonstration sites for communities. We can use the church as places to mobilize communities. We have specific media, including radio stations that are owned by the church that help us with messaging. And so we have done that, and even in the project that we did specific messaging. So we built the capacity of faith leaders, and they were able to mobilize from their pulpits and have specific messaging for that. And then they're also able to engage communities and reduce things like vandalism and promote ownership. There are other things beyond working with the faith leaders. So I didn't say much about what we do with the faith leaders, but we first of all, we sensitize them, and then we build their capacity, and then we work on messaging. We create messages that they can use from the pulpit. So if somebody wants to talk about WaSH on a Sunday, so we have developed material that they can use to talk about WaSH from the pulpit as well. And then beyond that, we have had shared learning across CHS. So we've worked with about, I think, by the time the project closed, we had worked with about 3,000 faith leaders. But beyond working with the faith leaders, we were also working with Christian health associations across countries, so that if something is working in country A, they're able to, because we have convening power, then we had a technical working group where they can talk to each other and talk about what works, what doesn't work, we're struggling with this. And then we also have the circuit rider model, so I am mixing a few things about things that we are doing. Because I talked about faith sector not having funding, that having to rely on out-of-pocket financing for the facilities, prioritizing WaSH has been one of our challenges. But as part of what we were doing on Momentum, one of the things we tried to do is a few countries have a WaSH point, a technical WaSH point of contact at the National Christian Health Association. But we were trying to make sure that at least there is one person in each country. And so these people, what we were doing is using the circuit rider model to provide technical mentoring and do visits to the various places. And there's a photo you saw at the beginning, and we have, that was in Uganda, and they're trying to repair some of the facilities in the country. And it helps us because we cannot afford, we are not able to afford technical people, but if there's at least one or two, then we can use those to service the country. And then we also have worked on digital monitoring for accountability. As part of it, I talked about the faith motivation. I talked about this before, but ownership and accountability. And for me, ownership and accountability here is talking about the faith leaders, involving them and making them part of the system, so that when they prioritize, they remember to prioritize WaSH needs. And then technical capacity within facilities, which I say is still a challenge to prioritize, but I think with increased sensitization that can be done. The faith leaders are sitting on the board, so if we have managerial buy-in within facilities, then we're able to do better. We still operate, faith-based health facilities must and have to operate within the guidelines, the national guidelines in their districts, in their regions nationally. And so we have been emphasizing the need for that to happen and to be engaged. And one of the things that I have noticed is that there's a lot of engagement with the WaSH sector and the public health sector, but the faith-based health sector needs to be brought in and continuously engaged. And then the continuous community engagement, we have work in WaSH, community WaSH. We're doing community WaSH and still engaging faith leaders to work with us. And then I think we have benefited a lot from partnerships with governments and donors. And we continue to ask, and especially because one of our biggest gaps is documentation. We do not have data to show what works and what doesn't work. There's a lot of work that is done by the faith-based, but I think because of the limitation in resources and capacity, we continuously invite partners that would like to help us, especially to document. And when we have done that, we have done a really good job in showing evidence and being able to scale using the evidence that we have. I think that should be by So I think this is just a repetition of, this is just a summary of it, that institutionalizing WaSH as part of quality of care standards is important for us. Strengthening leadership capacity, of course, expanding our community of practice between ourselves, and then deepening community partnerships, and trying to ensure that we move from project-based kind of, because all the work we have done to date has been project-based, and we need a system kind of engagement to make sure that we do not leave. The good thing with the faith-based health sector is that we are beyond projects. The facilities live and will continue to exist, and so if we institutionalize this, we are able to ensure that whatever gains we have made are sustained beyond projects. Yeah, that's my last slide. Thank you.
Thank you. Quick question? Yep.
Thank you for your presentation. Question about the financial sustainability of facilities in faith-based healthcare centers. So I'm wondering if you have any sort of insight. People give to the church, right? And there's probably denominational differences too in sort of how these different facilities are funded. And I'm wondering if you can share anything more about that, sort of like how I'm assuming these are funded by individual contributions to the church or to the to the denomination that somehow then get channeled. But again, there's differences. So I'm wondering if you could sort of speak to how the money flows to keep these things working.
So I think faith-based health facilities are in many ways already sustainable because they haven't received support as facilities, have always used out of pocket. So people pay for services. And the reason why people will go in many countries to the faith-based health facilities because of the quality of care. They're able to be seen faster and they will find the medicines there. They do not have to go and buy medicines from outside. So in many cases, there might be exemptions. So where the gap, as I see it, is that we need to sensitize the leadership in these facilities so that whatever model they use, one is they prioritize WaSH as they do their budget and their plans. And then another thing that we've continuously talked about lately is helping them to think of, and not in a way to make services unaffordable, but to think of healthcare business models that help them to manage facilities in ways that are profitable. Because in a lot of, they are providing, they've always been there. Facilities have existed for 100 years, 50 years. Communities have continuously gone to those facilities. They love them, they support them. But there's not a lot of business model kind of management, the management of facilities, and therefore that's why they're not sustainable in some cases. Yeah. And then of course there is the issue of there's the national health insurance in some countries that supports that. But if that now is external, and in some cases like Kenya lately, when that has not been working, it's been affecting them quite seriously. So being able to think, so we've been talking about how do we think about a private community health insurance. Yeah.
Thank you very much. All right, and finally, we've got Dr. Brima from DRI presenting on circuit riders.
Good morning, everybody. Yeah, Ryan, Bessie, and Nikki, thanks for inviting us. This was a short notice, so I had to come. But I have people on my team who work on this. I hope I can do justice to it. But I'm also happy that we are going to have the circuit rider, COP, and then we'll get some of our field staff to present. But my name is Brima Pambiri, and I work with the Desert Research Institute in Reno, Nevada, but originally from Ghana. I'm going to be talking about sustainability of WaSH services in healthcare facilities using the circuit rider model. I know my sister there already mentioned it, so you are familiar with it. So the circuit rider model was developed in the US here in 1980, and it was meant to respond to problems that were associated with small water systems. And it was developed by the National Rural Water Association here in the US in conjunction with the Ministry of Department of Agriculture. At the time, they had just passed the Drinking Water Act in the US here, so there was the need to have, repairs in small water systems. So since 1980, it's been functioning here in the US within rural and small water systems. It was taken down to Latin America, and then Canada, and then we now have different versions of it in developing countries. So we've tried to, modify it to meet the needs of long-term sustainability of water systems in developing countries. So they are qualified technicians that you train, and then they'll go around in a circuit, like electrical circuit, They don't wait until the system is broken down, but you train them, and then they go around to take care of the technical repairs. They also work with those who work within the water systems, water boards, and technicians. So their training is varied. It's not just the technical part, but they are also trained on financing, the circuit riders, administration, and then some hygiene promotion. So the chart here just shows how the circuit riders go around. And they go around a number of times a year, 4 to 6 times a year, addressing the problems before they occur. So they focus on preventive maintenance of infrastructure. And life cycle costing is very important in this. So what the circuit riders do is that, DRI does is that we provide the training and at least some seed money. We have different variations of the circuit rider program. We have one in Ghana that is total community-based. A year ago, we started going into healthcare facilities. The one in Honduras is with the district water board. We had one in Chile, and then the latest one is the one in Malawi, which we extended into healthcare facilities. So we had to modify it to be able to get into healthcare facilities. So they receive dedicated training from DRI. Our main partner there is in Malawi is Transform International, and our local partner there is DAMRA. So they are the host institution in northern Malawi, the district of Rumpi. So they can also help healthcare facility staff conduct improvement and maintenance plans. The secretaries are local community members, and they understand the systems in which they work. They promote monitoring, evaluation, resolution, and learning. We teach them a lot around that, especially, building databases using M-Water. So they are trained on all that. So as I indicated, the circuit rider program began in the US only on water, and now we wanted to extend it into healthcare facilities. And healthcare facilities have their own needs and problems. So this set of technical circuit riders are called technical circuit riders, which we have been working with in rural communities. So they inspect and maintain water and sanitation system, waste management infrastructure, conduct regular water quality testing, and then train healthcare facility staff on basic maintenance. Now, we introduced what we call the quality of care circuit riders, and they are all from the Ministry of Health in northern Malawi. So they have different training, that is around, health. So they train staff on cleaning, IPC, hygiene. They also do a lot of WaSH fit training. We train them on WaSH fit, and also to ensure that guidelines and protocols are followed. They coach healthcare facility managers and staff on workflow improvement. The two sets of circuit riders monitor and report on conditions on WaSH, and they work collaboratively to identify areas that they should improve. And as I indicated, they also do data management. They have means to be able to record all this. So what are the key components of the circuit rider program? This doesn't appear here. Yeah. So the key components are that if you are establishing a circuit rider program, you have to have a host institution. And as I indicated, the host institution in Malawi is DAMRA. It's a local organization there. One component is the circuit riders which we are talking about, the healthcare facility staff, and of course, the clients are patients and community members. So for the circuit riders, as I indicated, they receive training, and they go around in a circuit. One of the things that we've also done in anticipation of handing this off to government is to create an advocacy group. And the advocacy group is working with the government of Malawi, the parliament, the ministry, to see if there can be resources allocated to the healthcare facility so that they can run it in the long term. Now, so I just wanted to go into what we did. Transform and DRI, we did an assessment of 18 healthcare facilities in Rumpi district and identify issues that were associated with each of these indicators of WaSH in healthcare facilities. There was lack of continuous flow of water, inconsistent water treatment, no water quality testing, in sanitation, poor accessibility, no menstrual hygiene facilities, available toilets not functioning. Hygiene, hand hygiene, we didn't have, hand washing facilities and no soap in most of the places. Waste management, no incinerators, and they weren't collecting any waste to central locations. So these are the things that we found. There's a very detailed report on it. But based on the results, then we created the Security program in northern Malawi to be able to help the healthcare facilities. So we've had some significant gains. I don't want to go through all this. I hope all of you have the PowerPoint. But we've had some increases in positive perception. We have a very large, M&E program that we have developed, and we track some of these things. And I'll be happy to share a report. But there are some gains that we are already realizing in northern Malawi. The most important gain is that we no longer have water systems that break down for a long time before they are fixed. And one of the issues is also that most of the water systems are gravity spring systems, and because they are gravity systems, they are always contaminated with total coliform and E. coli. It's a very big issue in this program, and we need to be monitoring this, and then also to be working with government to do chlorination. So our securities are trained on how to test for total coliform E. coli in the water systems. And recently, DRI, we also helped the University of Livingstonia in that district with lab equipment so that they are able to analyze samples in the program. So water quality is a very huge issue there. One other highlight of this is that unlike our other security programs that they are all male, at least we have 2 females in our security program, in the Northern Malawi program. What are the challenges? Here some of my colleagues have already mentioned about funding. Very difficult to get funding, for long-term sustainability. I think already the system, our sector now, or most development, we are lacking funding. But for long-term sustainability, I think a lot of funders prefer to fund new systems rather than using it for long-term sustainability. So we are not able to scale these programs much at all because of funding. Issues of waste management, incinerators becomes a very big problem. Some places they say they should collect waste to a central location, and they are not able to do that, and then they don't also have incinerators. But we've been able to work with some of the healthcare facilities to be able to help them with that. I already mentioned testing, microbial contamination, a very huge issue. Support from the Ministry of Health. Once you have initial funding, you have to work very hard with government, Ministry of Health, to be able to get funding from government to continue. We recently hired University of Muzuzu to do assessment of the program, of how we can transition this program fully into government, with time. And we are studying the results now, but the problem is that we need to be sure that when these securities are integrated into government, they are being paid. Already the quality of care securities are government workers, but the technical securities are not. In other security programs, we use an entrepreneurial model. So we advance loans to the securities, and they are small businesses that they do. But for the healthcare facilities, we are not able to do that. So those are some of the challenges of the program in northern Malawi. They are not any different from most of the programs that have been presented here. So thank you, and if there are any questions, I will answer them.
Thank you, Brenda. So we've got about 10 minutes left, so we'll have the first question for Bryna. So if anyone has a question, and we'll go ahead and have our panelists come up, and we'd love to hear from Dr. Mary for her insights from government, and we'll kind of use the rest of our time for sort of discussion. So yeah, come on up. Anyone, first question though for Bryna, if anyone has any questions on his presentation.
All right, thank you so much for the presentation. I'm coming from Malawi, and I'm happy to see that you are helping us to improve the health service delivery in our country. But my question is just trying to understand your scope. Are you only focusing in the main healthcare facilities, or you are including other facilities like guardian waiting shelters? I'm asking this because in our setting in Malawi, we have guardian waiting shelters. This is a place where guardians who are taking care of their patients in the hospital stay. If someone has been admitted in the hospital for a week, it means this person stays at that specific guardian waiting shelter. And of recent, I think 2 years ago, we conducted a study in southern region of Malawi, where we found that WaSH services in these guardian waiting shelters were really bad, to the extent that people were taking diseases from the guardian waiting shelters to the healthcare facilities. So I just wanted to understand if you're going beyond the actual healthcare facility to also work or address issues around the guardian waiting shelters. Thank you.
For now, we are in the healthcare facility, so we work in all the 18 healthcare facilities in the Rumpi district, except the bigger hospital, the district hospital in Rumpi itself, and Livingstonia, the hospital there, we are not there. But I think it's a good direction, and we'll keep this in mind. I'll inform our project staff about it. But it's all about money. You know, we are so limited in what we can do. With the 18 healthcare facilities, some of them are Christian, healthcare facilities, and some of them are government. And we work in all those healthcare facilities. We want to get into the rural communities as well, especially the communities that are very close to the healthcare facilities. Where do you come from in Malawi?
In Blantyre.
I was in Blantyre for 3 weeks.
Oh, nice.
I just came back a week ago.
Nice. We'll catch up later.
Yes.
Okay, so, well, I just want to congratulate Darcy and Ryan and Nikki for organizing the session. I thought they were really fantastic examples, and I feel like I learned a lot and a good variability. So I hope you can do these follow-up webinars and share this more broadly. So let's turn to Dr. Mariashio to talk us through, I mean, we've seen a lot of different examples. Some of those are focused on specific WaSH services. Others are focused more on the WaSH package and the facility level. How does this resonate from a government perspective and different contexts, and what may be appropriate for Ghana or your experience in other countries as well?
Okay, thank you very much. Anne, can you hear me? Is it okay? Okay, so thank you for the presentations. I put down a few thoughts on each of the presentations, so I'd like to go through. So I think what I got from Daisy's presentation is that the systems thinking approach is still the most effective way of implementing WaSH in healthcare facilities. Because the interventions in each of the building blocks of the health system are critical, and one of them cannot fix all the problems that we have. So even if we have a lot of funding and we don't have the appropriate governance and the appropriate human resource, we still can't be able to implement WaSH in healthcare facilities effectively. So the first point I wanted to say is that management has to be a daily culture. So Daisy talked about having people who are focal points for WaSH implementation. So in Ghana, we track the proportion of healthcare facilities that have WaSH focal point. And as of last year, we're doing about 65%.
That includes the faith-based facilities, private facilities as well. So about 65% of all facilities in our country have WaSH focal persons. So these are people who on daily basis has to assess the gaps or the achievements in WaSH in the healthcare facility and then draw action plans based on the gaps that they see for improvement. So that is the role of making sure that management becomes a daily practice. It's not something we do 1 week and go to sleep and come the next month and do every day. Somebody must be checking that the standards are being met. Then in terms of governance as well, we also need, it's daily governance. So it's not beyond the focal point. We also have what we call improvement teams in every hospital that do WaSH. So these are people who are drawn from different sectors of the healthcare facilities. It includes clinicians. It includes administrators who work on infrastructure. It also includes cleaners who on a daily basis have to clean. So these are teams that come together to make sure that there's a daily governance in the healthcare facilities to implement WaSH. And we also see in Ghana's example that regulation must be very independent. So a few years ago, we introduced an organization called Health Facilities Regulatory Authority. But this is still an authority that is under the Ministry of Health. So you can't go into a facility that doesn't have WaSH services and close down the hospital because you as the regulatory organization, you are still under the Ministry of Health. And all the facilities are under the Ministry of Health. So in Ghana, whether you are Christian-based, you are private or government, you are under the Ministry of Health. So the regulatory system is there, but it's not so effective because it is under government. So we need regulation that is very independent. The organizational characteristics are usually context, and some of them are there, but they are not responsive. So we need those characteristics not just to be there, but being responsive to the daily needs of WaSH. When it comes to context, I think different approaches will work under different contexts, as we would agree already. So there's no one solution. I think all the models that have been said so far, if you ask which models work, all of them work, but under different contexts. And then the community participation is very, very important. We also need to have intentional funding. I think that in the last few years, we're talking a lot about countries having costed national budgets. Now, a lot of countries have those costed budgets, but they don't have any plans to actually recruit the funding. So if we have a strategy that is costed, and we know it will take us 1 million to implement costing, to implement WaSH in our country, for example, where is the 1 million going to come from? Is government going to bring 30%? Is private sector bringing 30%? Philanthropy? Nobody is talking about where do we get the money. So it's not just having a strategy and costing it, but government must then be responsible, bring all stakeholders together and say this is the costed budget. And this is actually how we are going to implement the costed budget. So Ghana has a costed budget strategy. Nobody is talking about it. Other countries are developing. Nobody's also talking about how we're going to get the money to implement that. So when it comes to the second presentation from Nuhu, I think one key thing I took was the fact that health sometimes can be very clinical, which is a challenge for implementing WaSH. We have the same experience in Ghana. Until I got on board in WaSH, doctors were not interested in WaSH because we think we should be doing, I don't know whether to say they or me, but clinicians usually think they should be doing more serious stuff. You know, like the big surgeries, head and neck surgeries, we are stitching vessels and, then we feel good.
Yeah, I'm a doctor, so yeah.
Okay. You see, and even when we were doing public health in medical school, it was non-scoring because we thought it was the easiest program. Nobody's really, actually we could sit down and learn the public health the day before the exam and still get, everything right. So it's difficult in clinic as well when after school they start practicing in hospital. It's a mindset, they are not interested. So when you recruit a couple of doctors who understand that for you to be able to provide the quality of care, you need to manage the system within which that service is delivered. So it's not just coming to hospital and doing surgery or giving injections. The same with nurses, but you are working within the system. And you as the healthcare provider have to be part of the system's thinking. So that was a challenge we had in Ghana as well. The nurses were more interested in IPC, for example, because of the work there. But again, they are interested in the clinical component of it. So when you get leadership of WaSH in healthcare facilities, that the front line is able to relate to, they now feel more comfortable. So that if they see Dr. Shinyo doing WaSH, they are happy to now come to the room and talk about WaSH. Because then now, nobody's going to tell them that, oh, we are talking about these things that the junior nurses come together to talk about. But there's a doctor talking about it. So I think leadership that is multidisciplinary, that the front line can relate to, can be very, very helpful in bringing the clinical teams together. And when they see value in the WaSH, when we begin to explain to them that actually why you are coming to do WaSH is to make sure your own work, the outcomes are better so that your patients are not coming back with hospital-acquired infections. And then you now have to use more antibiotics, and they now have to stay on the bed for longer. And then your patients now come and there's no bed because the ward is full. So when we begin to give them the economic aspect of it, and they realizing that, okay, it's not just an easy aspect of health, but it's actually a very important component of health that makes their own clinical work better, then it helps. I've seen Anne holding the mic, so I should stop. But I had just put a few points, maybe you come back or...
I think, unfortunately, we have to close. I need to be somewhere else, and...
All right, so I'll just end there.
But fantastic additions from your perspective, and I think to be continued, the conversation in future webinars. I think we had some questions already from the audience, so very glad that you put those in, and feel free to stop these questions. And we could share also the policy brief along with the presentation.
And we'll continue these discussions this afternoon. We've got time scheduled in for that. So come with your discussion. Thank you.
Right now, yes. How are things?
Our afternoon.
Good to see the presentation on circuit graders.
Yeah,
It's always exciting. I remember when Nancy was writing that proposal.
Yeah, we have this.
Glad to see.
Yeah. It's all discussion.
Part two.
You interact with other folks on the team quite a bit. Yeah.
So good to
I was not on the call, but thanks for
Thanks for
There's nothing new.
Yes.
you have to go to another meeting.
Same experiences.
Everyone's running.
Hello.
No, I know. Good to see you.
So is this safe?
Planning is
Presentations for 2 seconds.